Okay, so I'm going to go ahead and talk about the shoulder tonight. We're going to talk about some anatomy, some of the diagnoses and treatment, and some of the technology that's coming around the corner. Okay, let me start here. All right, so first we're going to talk about the basic anatomy, pathology, diagnosis, treatment, and then again, emerging technologies. The function of the shoulder is to connect the axial and appendicular skeleton, basically connecting the body to the arm. The shoulder allows a large range of motion, the positioning of the hand in space to function, and the more supporting structures there are, the higher risk there is of injury. So from all the way from the skin all the way down to the shoulder joint. The name of the shoulder articulation or joint is called the glenohumeral. The glenoid is the socket. The humerus is the true ball and socket joint. It's more of a golf ball and a golf tee, actually. You have bony prominences in the shoulder called the coracoid, which is the prominence in the front of the shoulder. The acromion is also known as the roof bone of the shoulder. Greater tuberosity, which is where the rotator cuff muscles attach, and the acromioclavicular AC joint, which is right up here. We have ligament structures, which I'll show you next, and then we have joint fluid in the shoulder that also gives us some cohesion and adhesion in the shoulder joint. The rotator cuff are basically the four main muscles of the shoulder. They function to rotate the shoulder in space and allow a position of the hand in space as well. There can be deconditioning of these muscles, and that can either lead to a cause of shoulder pain, or the shoulder pain can be a cause of rotator cuff deconditioning. The ligamentous structures are basically thickenings of the capsule. They act as a sling or a hammock underneath the ball of the shoulder. They control shoulder translation based on the position of the arm. So the functional position, basically the ligaments are kicking into position and tightening up. So the inferior glenohumeral ligament, or IGHL-C, is the primary static stabilizer of the shoulder in the functional throwing position, or 90-90 position. And like any other ligament, they go between two bones, and they act as check grains for range of motion. The labrum is, because it's such a small, thin socket like a golf tee, the labrum is actually white in real life, but is red in this picture. It acts as a bumper cushion to deepen the articulation by about 40%. It also attaches to the ligaments, so the ligaments attach to the labrum. So if there's a labrum tear, you essentially have a ligament tear. We'll talk about that a little later. The long head of the bicep sits up in the 12 o'clock position of the socket of the shoulder, and it causes some depression or holding down of the humeral head so it doesn't rise up when we're in a throwing position. Okay, let's talk about arthroscopy. Arthroscopy is a technique we use in orthopedics to look into joints and body areas with small cameras. It's a fiber optic camera, and we make small incisions. We pass instruments and implants through these incisions, and we can repair things by making just 3 or 4 little holes versus opening up a joint completely through an open incision. And it also decreases problems with surgical incisions as well, because they're so small. So how do we do arthroscopy? We make 3 or 4 millimeter portals around the shoulder. There's actually about 10 different portals you can make around the shoulder joint. We can introduce implants. We can pass instruments back and forth to repair things. So what we do, how do we do arthroscopy? We look in the shoulder joint, which we just talked about. We can repair labrum tears when people dislocate their shoulder. We can take out loose bodies of bone and cartilage, and we can fix shoulder instability. Then we can go up above the rotator cuff in the space which is called the subacromial, which means under the acromion bursa sac, and we can clean up, fix rotator cuff tears, and we can repair impingement syndrome, which is pinching of the rotator cuff, and we can address AC joint arthritis. We can also address a frozen or stiff shoulder, which can have pathology in both locations. So basically what we do is our diagnostic arthroscopy. We look around the entire shoulder joint 360 degrees. We want to look at the biceps tendon. We want to look at the labrum attachment all the way around. Then we want to look at the undersurface of the rotator cuff, and then we pop up in the space up top between the acromion and the rotator cuff. All right, so let's talk about pathology of the shoulder and how do we treat this. First, another thing we have to talk about is MRI, or magnetic resonance imaging. It's an always developing technology. As the magnets that we use get stronger, the pictures we can get are better. What they do is the magnet excites hydrogen atoms and has them all line up, and then different tissue densities appear at different colors on the grayscale in an MRI. And we can slice the patient in either coronal views or axial views or sagittal views from the side. And we always have to say, the MRI has to correlate with the history and the physical exam. We don't just treat the MRI, we treat the patient. Okay, so let's talk about shoulder instability. That means the shoulder, because it's such a small socket with a very big ball, can dislocate or pop out of joint. There can be traumatic instability where somebody has a sports or a work injury trauma. It can be atraumatic, meaning it just happens, people are loose jointed. It can be one direction, primarily anteriorly to the front of the shoulder and inferiorly to the lower part of the shoulder, or it can be multi-directions where the shoulder comes out of place during multiple different directions. So we want to ask when somebody comes in and they sound like they had a shoulder instability episode or a dislocation, is this the first one you've had or you've had many of these? How many dislocations have you had? What do they play and where are they in their season? And we want to know if they have any related conditions such as ligamentous laxity, such as disease such as Ehlers-Danlos syndrome, or any kind of disease that causes ligamentous laxity. For example, somebody who can put their thumb to their forearm, I cannot do that, but other people can. That indicates one of the signs of ligamentous laxity. So we want to look at range of motion of the shoulder. We want to check their strength, make sure there's no nerve palsies from the dislocation. We want to again check ligamentous laxity. We want to do a provocative maneuver, which is called an apprehension test, which is in the lower part of the screen here, which is where we can lay somebody or sit somebody up and put their arm back in that 90-90 position. If the ligaments are disrupted or torn or the labrum is torn, they will feel their shoulder come out of place or feel like it's going to come out of place, which they're apprehensive about. So we want to do regular x-rays looking for a fracture. Then we want to do an MRI with or without intra-articular contrast or contrast in the shoulder joint. So if it's an acute injury, usually there's enough fluid and blood in the shoulder that we don't need to do contrast. If it's a chronic injury and there hasn't been a recent dislocation, then we oftentimes want to do it with contrast. We want to look at the labrum tear. You can see here in my arrow, there's a labrum tear down below here where it's torn off the socket. And there's another one up here in the superior labrum or a slap tear, the upper part of the labrum where the biceps attaches. And then over 50 years old with a dislocation, we want to be very concerned about rotator cuff tears. About 50% of people over the age of 50 who have a dislocation in the shoulder will have a rotator cuff tear as well. So not every shoulder dislocator needs surgery. I am one of those people. I've dislocated mine 3 times, never had surgery. So do I pay for it now at 54 years old? A little bit, but I do have a functional shoulder. There's physical therapy and a home exercise program. It's usually a short period in the sling. Surgery, usually we are doing arthroscopic surgery these days. It's very rare. These days we're doing open surgery, primarily for revision surgeries, but 99% of the surgery I do for instability is arthroscopic. And who do we pick for surgery? Based on the history and physical exam, do I have a contact or collision athlete? Do I have a football player who has just finished their season? What's the risk of re-injury? Do I have a police officer or a firefighter who's got to trust their shoulder? And more importantly, other people have to trust their shoulder. Is the first time dislocation, should we fix that? This day and age, 2024, we oftentimes will repair the first dislocation because it's such a high rate of redislocation in some high-risk populations, such as contact or collision athletes, other people have to trust their shoulder, for example, law enforcement or firefighters. And I really feel like arthroscopic surgery is the new gold standard for this problem. Okay, so after we fix do the surgery, we go in there arthroscopically, we repair the labrum back with little anchors that we use. We put the patient in a sling like this onto the right for about 5 weeks. We use an ice water cuff around the shoulder. We usually start therapy about 10 to 14 days post-op. And again, really senior patients are over 25. Under 25 is our most common population for this surgery. Okay, let's talk a little bit about osteoarthritis of the shoulder. Osteoarthritis is basically a wearing down of the surface cartilage of the joint. It can be post-traumatic from multiple dislocations. It can be post-surgical. There are some surgeries that were done in the old days that over-tightened the shoulder and made the shoulder joint break down. You can have somebody with a chronic rotator cuff tear, which we'll talk about in a little bit. And again, it can also be from multiple dislocations. You can see here, the space between the ball and the socket is really 0, and there's basically bone-on-bone arthritis here. So not everybody who has arthritis of the shoulder needs surgery. We can treat that with anti-inflammatories, cortisone injections. We can do viscosupplementation, which you may have heard talked about if you've gone to any of the knee lectures. This is done off-label in the shoulder. It's not approved by the FDA, but we can do it if we want. Physical therapy and decreased activity level, a lot of people don't want to do. Sometimes for a younger patient, I mean under 50, we can do an arthroscopic debridement where we clean up the shoulder. We get rid of all the arthritic fragments of cartilage. We can clean up bone spurs. Shoulder replacement is the gold standard for this, and partial replacement and then reverse shoulder replacement for somebody with a chronic rotator cuff tear is an option as well. This is what a shoulder replacement looks like. It is an open surgery. There's no way to do this arthroscopically. So what they do is replace the ball with metal and plastic stem. And what you can't see here, there's a plastic socket on the glenoid, and that is what the bearing surface is, plastic socket and metal ball. We want to get people moving early. Again, because if you have to do this open, you do have to take down some of the rotator cuff to get in there. So we do have to protect that early on. Usually recovery is about 6 months. It is very good for pain relief. Function is okay. A lot of times the function is predicated on how your range of motion and function is before the surgery. Okay, let's talk about shoulder fractures, or we call the proximal or upper end of the humerus. So this is described by Dr. Neer in fracture fragment or parts. A part is described as basically a piece of bone that is displaced more than 1 centimeter or angulated more than 45 degrees from where it's supposed to be. So technically you can have a 0-part fracture where the bone has not moved at all, or we call it non-displaced fracture. You can also have up to a 4-part fracture where the 4 parts are basically the two tuberosities, the greater and lesser tuberosities where the rotator cuff attach, and then the neck of the humerus, and then the ball of the humerus. So that's your 4 parts. So you can have a 0-part fracture, you can have a 4-part fracture with a dislocation as well. So these are treated differently. 90% or more of these are treated non-surgically. As I become farther along in practice, I treat less of these with surgery, but we have very good fixation options if we do need to do surgery. So the 10% of surgery, most of those are going to be open reduction internal fixation, where we put over here in the middle a plate and screws. And these are actually more like pegs that are locked into this plate. So almost like if you took your fingers and held up a basketball with the tips of your fingers, that's what these plates do for the ball. It's a very high stress area of the body and a high failure rate. So that's why these plates come around about 20 years ago, really big improvement. We can also do a partial replacement or a total shoulder replacement or a reverse shoulder replacement for a fracture that is irreparable, which there are some like that. Again, sling mobilization for about 1 month. We want to get people moving early, but we do want to protect the fracture fragments so they don't get pulled away. The rotator cuff muscles are pulling on those fracture fragments, so we don't want to activate the muscles too early. It's really about full coverage is about 1 year. I know that sounds crazy, but it really takes about 1 year. I usually follow people for about 9 months with these to see how they're doing. Unfortunately, these are limb and shoulder altering injuries. Even in the best case scenario, there is some loss of function with the shoulder. Even in a great looking repair and a great looking healed fracture, we still lose function. Okay, and the higher part of fractures, the more parts there are, the higher risk there is for a bad outcome. Younger patients, less than 50, usually do better than older patients. Let's talk about clavicle fractures, another most common fracture in the shoulder area. You can see here's a classic displaced, we call a Z fracture of the clavicle. So what happens is the muscles of the neck pull the medial piece up, and then the lateral part or outside part gets pulled down by the weight of the arm. These oftentimes, again, 90% or more of these can be treated non-surgically. However, this previous fracture that I just showed, that's the one that usually needs surgery. This one here, because it shortens and basically the arm instantly rotates and they lose their normal length and tension relationship of their muscles, so that the clavicle acts as a strut and holds the shoulder out to length. So how do we do that? Again, about 20 years ago, these plates came around. They're made specifically for the clavicle, and they're actually contoured. It's hard to see, but they're shaped like an S, like our clavicles are. And we can basically pick different contours and lay it right on the clavicle, and has a very high success rate, usually about a 3-month recovery. Okay, let's talk about separated acromioclavicular AC joint separations. These are very common injuries in the shoulder. They are grade 1 and 2, where you basically get sprains of the ligaments between the clavicle and the acromion. And then in grade 2s, it's a tear of the ligaments between the clavicle and the acromion. But the more important ligaments between the coracoid and the clavicle are intact. As we get higher grades, like for example, we just fixed a grade 4 today, where it goes up and back and all the ligaments are torn in the shoulder, those need to be repaired. So we usually will do surgery reconstruction. We try to do these acutely because they tend to do a little bit better than if we wait on them chronically. The grade 4, 5s, and 6s we fix. The grade 1s and 2s we don't. The grade 3s, like over here, are controversial. Sometimes we fix them, sometimes we don't. Okay, so this is what I do. I use a donor graft to make new ligaments. I also use a little metal button between two metal buttons that go between very strong suture to hold the distance between the clavicle and the coracoid in place. I do this open. There are ways to do this arthroscopically assisted as well. And usually, unfortunately, when something in orthopedics has a lot of procedures, That usually means they have very mediocre outcome. I think this technique seems to work pretty well in my hands, and I've had very good success with it. Okay, let's talk about frozen shoulder, also known as adhesive capsulitis. It's most commonly idiopathic, meaning it just happens. It is increased with diabetes, and in the Mercer County area, it seems to be increased with women who are in the perimenopausal region of their life. Okay, it's an insidious onset. It can be idiopathic. It can be post-traumatic. For example, if somebody falls on their shoulder or has a rotator cuff tear and traumatize their shoulders, or post-surgical, where somebody just gets stiff after surgery for whatever reason, their body responds poorly to the surgery. These are difficult to treat. The harbinger of adhesive capsulitis is decreased motion with increasing pain. And these stages are basically somebody's getting stiff, they've stiffened as much as they can, and now they're starting to become not stiff. That whole stretch can last between 18 and 24 months. Okay. The physical exam shows a decreased range of motion, especially with external and internal rotation. They usually have normal strength. They can oftentimes start as what we call impingement syndrome, which is pinching of the rotator cuff, which I'll show you in a second. Again, most of the time we can treat this non-surgically. You see this is a trend in orthopedics. We try to treat things as non-surgically as possible. We can treat that with anti-inflammatories. I think a cortisone injection in the shoulder joint where the frozen shoulder is and some physical therapy usually solves this 95% of the time. Once in a while, we have to take somebody to the OR who we have to do a capsule release. And then we also sometimes treat the associated pathology if somebody has a traumatic rotator cuff tear. And then they also have a frozen shoulder because they haven't been moving their shoulder because it hurts. We have to address both problems simultaneously. After we do surgery for a frozen shoulder, I put the patient in therapy the day after surgery, 3 to 4 days a week. We want an aggressive range of motion. One of my frozen shoulder patients coined the term, the pain of gain, meaning it hurts, but you're getting something out of it. We also have what's called a dynasfoot, which is basically a big spring, which will stretch the arm up in this position and try to do it while the patient is at rest and not in therapy. Works very nicely. Okay, let's talk about impingement syndrome. This is the most common thing I see in the office period. This is from rotator cuff aging, or we call tendinosis, which is degeneration of the rotator cuff. It's usually pain with overhead activity like this, and there can be some weakness. It's usually like a dull toothache. It doesn't usually wake you up at night, but it can if you lay on the shoulder. It can occur from repetitive use. It can occur from trauma because of secondary poor shoulder mechanics, like throwing a sledgehammer. There can also be underlying anatomical variations of the acromion, which can develop a bone spur or a point on it that can rub on the rotator cuff. What we want to do, we want to check range of motion, make sure it's not a frozen shoulder. I want to check somebody's strength. We're going to do these provocative maneuvers, which is the Hawkins sign, which is this rotation maneuver, and a near sign, which is bringing the arm up overhead. And we also want to do an AC crossroad test because sometimes they can get impingement syndrome from arthritis in the collarbone joint. And again, we also want to watch for frozen shoulder. Sometimes, again, it can start out as this, and if it's been there long enough, some patients who are at risk can develop a frozen shoulder after having impingement syndrome. And again, I'd say this is more like 99% conservative. Usually it's anti-inflammatories, physical therapy or home exercise program, and a cortisone injection. Very rarely are we doing decompressions of the shoulder joint, which I'll show you in a second. In isolation, usually it's associated with a rotator cuff repair. So this is what we call subacromial bursoscopy or arthroscopy. This is how we do this. What we do is essentially go into this bursa sac here, and we will fill it up with water like a water balloon. We'll put our scope in there, and then we can see the acromion. We can also see the rotator cuff. The acromion, if it has a bone spur or a large hook from an anatomic variation, we can shave that off. We can also take out arthritis in the collarbone joint, and this is oftentimes done along with a rotator cuff repair. So you can see here, if we had a burr here, you have a little hook or a bone spur on the acromion, and we would smooth that out with the burr, take out the dotted line, and we have a nice flat surface, so when the patient raises their arm over their head, it doesn't pinch on the rotator cuff and irritate the bursa in the rotator cuff. So afterwards, there is no restriction in range of motion, sling for a couple days. Usually it's about a 3-month recovery. It's about the shortest recovery of the shoulder of anything we do. Again, comparing that to a fracture, which could be 12 to 24 months, it's a pretty short recovery. Most people do very well, but again, very rare surgery these days. Much more popular back 20, 30 years ago, but not very common these days in isolation. Okay, so rotator cuff is kind of like the coup de grace of the shoulder. Very common in people 40 and up. They can be acute from trauma, or they can be chronic from wear and tear, from chronic impingement syndrome and chronic tendinosis. There can be associated injuries as well. We'll talk about that in a second. So I want to get a really good history from somebody who I think has a rotator cuff tear. I want to get a good history from anybody, but really rotator cuff, very important. Did they have an injury? Did it just come on spontaneously? Do they have pain in the front of their shoulder? Is there weakness? And night pain is very common. Not lay on your shoulder night pain, but I always make a joke that if they could sleep, they sleep standing on their head, and they have night pain. That's a rotator cuff tear. So it doesn't matter what position they sleep in, the shoulder wakes them up, and it's not a wake up and roll over to the other side and fall back asleep. It's a wake you up and you can't fall back asleep kind of night pain. You want to look at inspection. You want to look at for any kind of muscle atrophy, like this gentleman here on the left has some scalloping of his rotator cuff muscles, which if he has a tear, it tells me it's probably more of a chronic tear because the muscles have atrophied. I want to check their range of motion, make sure it's not a frozen shoulder. I want to check their external rotation like we're doing up here on the right. That is to me the classic sign of a rotator cuff tear. If somebody has weakness when I resist their external rotation, that is a rotator cuff until proven otherwise, as far as I'm concerned in my practice. So how do we do the diagnosis? We want to hear the history. Was there a fall off a ladder? Did you trip and fall down the stairs? Is it just something that happened over time and wear and tear? And before you know it, they started waking up at night with shoulder pain and night pain. You always want to get x-rays because that will tell you a lot about the bone, whether there's arthritis involved as well. You can see here in the picture, this is the ball and the socket. This is a coronal view of the rotator cuff of the shoulder. That looks normal. This is the tendon right up here. You can see it's torn off the bone, and all this white blood or fluid is indicating the bursa space where the rotator cuff has detached and torn. Some partial tears can be part of the normal aging process, but a full thickness tear usually occurs from wear and tear, but it also can occur from trauma. Like this one has all that fluid around it. This is most likely a traumatic rotator cuff tear. Somebody had an injury. All right, and again, not every rotator cuff needs surgery. Over the age of 65, about 50% of people have rotator cuff tears. They don't all line up outside my office looking for surgery because a lot of them are asymptomatic or don't actually need surgery. So we can do corticosteroid injections, we can do anti-inflammatories, physical therapy. That typically works for people over the age of 80. I'm not going to judge, but 80, I've done a couple 80-year-olds in the last year, have done very well. But 80 is typically a number. 75 to 80 will consider not doing surgery if somebody doesn't really want it. But unfortunately, the rotator cuff will not heal on its own. And unfortunately, I would make a joke, that's what keeps me busy every week. So we will do a repair, arthroscopic repair 99% of the time. Sometimes we can only get part of the rotator cuff back if it's a really big tear. And doing a partial repair 3/4 or 90% of the rotator cuff, we can get a good outcome. Sometimes a cleanup or a tendon transfer to reconstruct the rotator cuff. There's also biological augmentation, which we can use to help enhance healing on a chronic tear or a re-tear. Sometimes these don't heal, unfortunately. Usually people do better if they have an acute traumatic tear if we get to them within 3 months. I know that doesn't sound acute, but by the time somebody realizes they had a rotator cuff tear, gets in to see us, we get an MRI, and we get them scheduled for surgery, that can sometimes be 3, 4, 5 months. So anything 3 months under, I find anecdotally does a little bit better. Okay, so what do we do with the arthroscopic rotator cuff? We want to look in the shoulder joint first. We want to see if they have any arthritis. We want to see if they have a labrum tear. We want to see if they have a biceps tear. Then we move, once we've evaluated that, we want to look at the space above the rotator cuff underneath the acromion. Then we have to mobilize the rotator cuff and prepare it to put it back in place. So you can see here, this is a classic 2-row, 4-anchor repair, where we basically take the rotator cuff and we stitch it back down to the bone. Essentially, we take it like this, we lay it down on the bone with this contact surface area like that, and that's our repair. We will usually do a subacromial decompression if there's a bone spur, because that usually contributes to part of the tearing. And then we will address the biceps tendon sometimes as well, and I'll show you that next. Okay, we do a sling for 5 weeks in my practice. We do ice therapy. Sometimes therapy can start as early as a few days after surgery if they have a frozen shoulder, or up to 21 days if I have a massive tear or somebody who has a re-tear. It's a 4-phase rehab. We want to start with passive motion. We want to protect the rotator cuff. It's very similar to the shoulder fracture rehab. Actually, I use the same protocol. We want to do active motion and active assisted where you're helping it after about 6 to 8 weeks. Then we want to progress strengthening. A full activity for a small tear, 3 months, probably more like 4 or 5. Could take up to a year to really get over the shoulder. I'll get over the rotator cuff surgery. So I tell people when I discharge them at 6 months, they're really about halfway there, but really they're about 90% of the way there. But it takes about a year to get up to that 95 or 100% function. Recovery time definitely correlates with the size of the tear. The bigger the tear, the longer the recovery. There have been a number of studies showing even up to 2 years post-repair, people will continue to improve slightly. But it really, I find 1 year post-repair is where they kind of plateau. Okay, let's talk about the biceps tendon. So there are two tendons in the biceps, hence bi meaning two. There is a short head, which attaches to the coracoid. Then there's the long head, which runs up the humerus, around this corner, around the humerus, and attaches to the top of the shoulder socket. It sits in the bicipital groove. You can get tears of the biceps. You can get dislocations where, from a trauma, it pops out of the groove, very commonly associated with a tear of the front rotator cuff tendon. I call it the appendix of the shoulder because it doesn't do anything good for anybody except cause problems. Even overhead throwers, it's a question whether it really does anything. We want to do a couple tests right here. This is the Speeds test right here. This is the Jurgensen's test. We want to put our finger up in the bicipital groove and move the arm around and see if it hurts. And if they have bicipital groove thing, it could be a bicipital tendon problem. Usually it comes in conjunction with rotator cuff pathology because the rotator cuff sits right next to the biceps tendon. So what do? For treatment, non-surgical treatment, we can inject it with cortisone. It's a difficult diagnosis because it oftentimes goes along with a rotator cuff tear. Sometimes people will rupture their biceps and they get what's called a Popeye muscle deformity, where the biceps shoots down here and balls up down in the arm area. Usually we will leave those alone if I have a young, active patient and if they get a lot of cramping in the biceps because of the new length of the muscle now. We'll actually do an isolated biceps tenodesis where we move the biceps back up into the groove. We'll make a little incision under the armpit and we'll bring the biceps back up. Usually we'll try to treat this non-surgically if possible. And again, usually if there's a biceps tear in conjunction with a rotator cuff tear, we will address the biceps. Usually what's called the tenodesis. Teno means tendon, desis means move. So we move the tendon to a different location. Usually, again, right under the armpit, we bring it right under the chest muscle. As you can see in this picture to the right, we've kind of moved it under the chest muscle with a little small incision under the armpit. Very cosmetic. Okay, again, usually performed with a rotator cuff tear, and usually the rotator cuff takes priority in the recovery time. If it's isolated, we usually can get somebody better in about 3 or 4 months with a biceps tenodesis, but we don't want them doing doorknob movements or resisted elbow flexion for about 8 weeks to protect the repair. Okay, so let's talk about some emerging technologies. We have orthobiologic agents. We have bone graft substances that we use a lot with our fracture work. We put some of that around or into the fracture to try to help it heal and induce it to heal. And it will be conductive. The materials are actually porous, just like real bone. We also can use things like platelet-rich plasma, stem cells, which is not really very commonly used in orthopedics, and bone marrow aspirate we put in to biologically enhance the healing of either soft tissues or bone. We use biological cements where we can actually, it's almost like a coral material. We can inject it wet like a cement, and then it hardens and fills the space and can biologically conduct bone and induce bone to grow through the little pores of the structure. We can also put scaffolds, for example, like this picture right here. We can do a repair of a tendon and add a scaffold over the top of it to try to enhance the healing. This is usually a collagen matrix. So these are some of the things that are coming around the corner that we're using now to biologically enhance the things that we do in orthopedics, especially in sports medicine. In conclusion, shoulder injuries are very common. We, again, conservative, I try to stress this, is very important. Not everybody walks into my office. Probably about 90% of people walk in the office are not getting surgery. That means there about 10% are. So we really try to treat people non-surgically if possible. The outcomes are improving with technology. Again, rehab, again, is super important. There's an old saying that a good surgery with a bad therapist can make a bad outcome, and a bad surgery with a good therapist can make a good outcome. So therapy is super important, both in a plus and a minus way. I think as we get better, we're improving imaging technology, so we can really diagnose things a lot better. And I think the biological enhancement is really going to be a huge key in the future to enhance what we do surgically to try to get our outcomes to not be 95%, but get them maybe 100% or 99%. That's the ultimate goal, is to be 100% perfect. Right now, it's a goal. It's not attainable right now, but hopefully between technology and technique, we can get to 100%. Oops. Thank you very much. I will take any questions if there are questions out there.
Dr. Hornstein?
Yes.
This is Diane, and we did have a number of people who did submit questions. So
Okay.
if I could read a few of those off before we
Okay.
open it up.
I'm gonna show my age and put on my reading glasses. Okay. So
Oh, well, you
sorry.
don't you won't be able to see some of them because they were sent directly to me. One is, I am a 38-year-old woman. I have calcific tendonitis in my shoulder from the way
Right.
I was holding my arm up in an awkward position on my computer desk. I saw an orthopedic surgeon and got diagnosed after the pain that I'd been having for a few years. Suddenly got a lot worse. He did not know why it happened since my liver and kidneys are fine. I got rid of the pain by taking a double dose of acetaminophen for a few days, prescribed by the doctor, and did physical therapy. She did not need a cortisone shot. Her question is, does the calcium in the tendon eventually go away if you've addressed the cause of the inflammation, or does it stay permanently? Can it cause problems when she gets older? Is it possible to surgically remove the calcium without messing up the tendon? And is it important to get rid of it even if you're not having pain?
Okay. I'll start with the first question. This is one of the kind of the great unknown entities in sports medicine. Why people get these really unknown. Any tissue in the body can become calcified or ossified. Any degenerative tissue. So in this case, the rotator cuff is the degenerative tissue, and it can become calcified or ossified. These kind of come in two varieties. The one variety we see, I just saw somebody yesterday who I saw last week. The worst pain they ever had for 48 hours. He went to the ER and they missed the calcium deposit on the X-ray. We fortunately were able to look at it because I just knew how he was presenting. We saw it. I gave him a cortisone shot, and it went away within 2 or 3 days, and he was great. That one usually stays away. The one that this patient is describing usually can kind of linger, and those oftentimes require surgery because they kind of wax and wane. The calcium deposit does not seem to go away. It seems to stay there, and nobody really knows what the pain generator is. My theory is that the calcium kind of eludes out of the rotator cuff. It's almost like snow globe material that when you shake it up and it kind of gets in the bursa sac and really causes inflammation. That's why the cortisone shots work so well. If we do surgery, I have certainly seen people try to go the non-surgical route or like the non-invasive way of either trying to have somebody suck the calcium out under ultrasound. Problem is it's really kind of chalky unless you get it really, really early. That's when it's kind of liquidy, but usually it's kind of like almost like chalk. So you have to almost excavate it out of the rotator cuff. And then unfortunately, when you do that, you do end up with a small rotator cuff tear that you have to repair. So that's usually how, if I have somebody who's just not getting better, I've tried shots, I've tried therapy, they're just not happy. We do an arthroscopic surgery. I go in there, I will locate the calcium deposit. Sometimes it's a little hard to find because it's in the rotator cuff layers. So we use a little needle to poke around until we find the chalk. Then we excavate it out and we do an arthroscopic repair. Usually people do very well after about 4 months of recovery.
Terrific. What should a patient do if 3 months after arthroscopic surgery and having done physical therapy faithfully as prescribed, shoulder pain is worse than before surgery? In this case, there was only arthritic inflammation and a bone spur. No RC tear was present.
Rotator cuff, right. So I'd be concerned that the arthritis, and how old is this person? If they could maybe mention that.
They did not
Yeah.
disclose that.
Okay. So the arthritis is always an X factor. When we find that and it's just arthritis, I usually do a pretty extensive cleanup. I will take out a bone spur on the ball and on the roof bone. And then sometimes the biceps tendon is degenerative as well. We have to move that with a tenodesis. So my concern would be one of two things here. Either the arthritis wasn't cleaned up enough, or it's just that's what's still inflamed, or you're starting to develop a frozen or stiff shoulder, because that's a very common cause of post-operative pain. For somebody is not getting better, that's a very common reason why.
Okay, I have two more questions that were submitted in the chat box, and then we'll take the microphones off mute. The next question is, can you give your opinion on bicep tenodesis on elderly patients age 70 plus with a rotator cuff repair? Do it or not? In Arizona, almost all patients have done this no matter what the age.
Okay, so ironically, this is one of our good physical therapists that used to work with us back in the old days. He moved to Arizona because he likes to play golf a lot, and he still works. So my opinion on tenodesis is, in this country, tenodesis is kind of the gold standard for rotator cuff surgery, or for any patient for that matter, because what happens is if you do what's called a tenotomy and cut the biceps, you'll end up with a Popeye muscle deformity 9 times out of 10. And some people don't like how that looks. If you talk to them ahead of time, sometimes you can kind of head that off with the pass. And but a lot of people want to look normal and feel normal, and they can also get cramping and spasm in the muscle if you do a tenotomy. So to me, I will usually do a tenodesis unless I've had that conversation ahead of time about the biceps, or if they've already ruptured it, and I explain to them that it's more surgery to go chasing after it. If I'm doing the rotator cuff, a lot of times we'll just leave it alone.
Okay. The next question is, can you say more about difficulty sleeping on either side due to pain in shoulders?
Say that again. I'm sorry, I did not hear you. I'm sorry. Go
Can you
ahead.
say more about the difficulty sleeping on either side due to pain in shoulders? And whoever submitted that question, feel free to take your microphone off mute and ask that question and provide a little bit more information.
That was me, and I was asking for my husband, who is about to turn 80. He's in
Right.
excellent shape otherwise, but he cannot sleep on either side. He's
Right.
had shoulder x-rays, and I don't think it showed any pathology, but then again, at one point he did get a shot of cortisone into the joint. So that did help, but it set his diabetes off, so
Right.
wants to avoid that again.
Yep.
So
So
what-
I'm sorry, go ahead. I'm sorry, I didn't mean to interrupt. I thought you were done. Go ahead.
So I was just hoping that you would be able to suggest something that would give him some relief.
Yeah, I mean, sometimes physical therapy helps. I mean, it really depends. You have to know what you're dealing with. Are we dealing with arthritis? Are we dealing with a frozen shoulder? He's diabetic. Are we dealing with a rotator cuff tear? Would be my number one guess on the situation. If he's in good shape, otherwise, I've done two 80 and 82-year-olds in the last 6 months. They probably were my best two patients of the year. So I'm not afraid to do the surgery if they can medically tolerate it. I think 80 is the new 70 and 70 is the new 60. So I think people who are active, they want to do stuff and their shoulders are hurting them and they can't sleep at night, they should have something done. And cortisone shots are oftentimes just Band-Aids. And if I have something who's really active and they're not, so I mean, I would really have to assess his overall health and see, certainly MRIs and things like that to see what's going on.
Okay, and how about over-the-counter ibuprofen or something?
Yeah, I mean, I have a bad, from my dislocations, I now have an post-traumatic arthritic shoulder. I play a lot of pickleball. I take Advil every time I play, three ibuprofen, or four every time before I play, a half hour before I play. So I think it's a good drug. You can modulate the dose. It's not a prescription. It works just as well as the stuff we have to prescribe. And it's over the counter.
Thank you.
You're welcome.
The next question is, my shoulders are hurting when I am sleeping. I suppose it's old age. What can I do to improve movement?
Well, I mean, now the question, this comes back to the sleeping pain. Is it pain when you lay on the shoulder or just pain anywhere? Because it depends, it could be rotator cuff pathology. It could be impingement syndrome. It could be, rotator cuff tendonitis or bursitis, which are equivalent to impingement syndrome. So really, again, to me, it's hard to, night pain, can be from a lot of different things in the shoulder. You really have to kind of get, drill down to the history and the physical exam, and then the imaging studies, the x-rays, and if we need MRIs. So.
Next question is, how would you describe pain in the upper arm? No shoulder pain, reaching up or out is painful. Some arthritis, age 71.
Right. So that pain is usually, pain in the shoulder is usually not here. It's actually usually more down here, kind of in the badge area of your shoulder. So that's a very typical referral spot for shoulder pain. So it's not always up in the shoulder itself. Sometimes it gets down the arm a little bit even. And sometimes people even complain of like arm weakness or pain. We call that a dead arm syndrome, which is a bad term, but it just indicates that when your shoulder is hurting, just your whole arm just doesn't feel like it's working right or feeling right.
Okay. Those are all the questions that came in through the chat box. If anyone would like to ask the doctor a question, you can unmute yourself and ask via the microphone.
Hi. I'd like to ask a question if I could.
Yes, go ahead.
Okay, thank you. I'm 65, have had frozen arm previously,
Mhm.
and also surgery on my left bicep previously.
Right.
Uh, have been not having any problem lifting weights until recently. And now my traps, in particular on that arm that had the surgery, the muscle spasms constantly, especially at night when I'm resting.
Right.
And so I've had physical therapy, but it's not getting better at all.
Right. That's a tough problem. I kind of, as a just to keep myself sane at work, I call that no man's land because it's not really your shoulder, it's not really your neck, it's kind of in between the two.
Right.
So for me, like somebody comes in with that, we have, I'm a physician, we have medications and things we can try, but a lot of them are sedating. I like either trying massage therapy. Certainly physical therapy is a good place to start. Massage therapy, acupuncture sometimes helps people.
Yeah, I
Um,
didn't know.
we do have pain management doctors that do trigger point injections where they'll inject little injections of local anesthetic into the muscle to try to break up the spasm. It's a really hard problem. I don't have an answer for that one. It's a really hard
Okay.
problem. You do have to
Okay.
make sure it's not coming from your neck as well.
Yeah. Yeah. I do a lot of the neck exercises,
Right.
um, especially for, bad posture. But
Yes.
yeah, I've been really working on that and not having a lot of luck.
Yeah.
But thank you.
Have you tried any alternative stuff that I mentioned?
I have. I've had acupuncture, and just today, for the first time, I had those numbing shots, I
Trigger point
guess.
injections. Good.
Yeah, but it actually is pretty sore
Yeah,
right now.
it's a really hard problem. And also you gotta look at like your bed, your pillow. I mean, you gotta look at every avenue that could be causing this.
Yeah.
It's a really hard problem. I kind of cringe because I can't really fix that problem. I try to make it manageable, but
Yeah.
I can't really fix that problem, unfortunately. It's a hard one. Because
Okay.
those muscles have to hold up your head and they have to keep your shoulder blade in position at the same time. So they're kind of doing, double duty.
Right. Right. Getting that neck strong enough.
Yeah.
I want to continue lifting, so I guess I should just keep going anyway.
Yeah, just, I always tell all my patients, whether they're surgical or not surgical, if they have a shoulder issue, avoid behind the head and overhead stuff. So you want to see your hands for your exercises. Like here, I can't see my hands. But presses and curls are fine. So you really want to avoid like the skull crushers and the lat pull downs and the military press stuff. That really tends to aggravate the shoulder.
Oh boy. Okay.
Sorry,
That's
not what you
okay.
want to hear,
Thank you.
but you're welcome. Yeah, Diane, there's a question here.
I can read it. I am a
Go ahead,
56-year-old male who has played baseball, tennis, and lifted weights since high school. I recently was diagnosed with a rotator cuff impingement. When I lift weights and play tennis, my shoulder becomes painful, but it doesn't prevent me from doing activities. Are there exercises or strengthening I can do? Followed up with, I notice arm circles and push-ups before tennis and lifting help. Would impingement ever require surgery?
So again, I guess I don't know what the treatment was. So if it was the treatment was just, yes, there's exercise. So if you go online on Google and you put in rotator cuff exercises, there are multiple exercises where you can do, cans, empty and full cans. You can do sideline rotator cuff. You can do front raises. All those kind of things are great exercises for the rotator cuff. The problem with the rotator cuff muscles, they are very small muscles that have a very big job. Their job, they have to lift that arm up, and they are very tiny muscles compared to like your pecs or your lats or your traps or your quads. And so it's kind of a bad setup. And that's why we get impingement because, really, again, if you think about anatomically, we were meant to run on all fours, right? And then we became people who we lift above overhead. So those muscles were basically formed propellers. They were secondary muscles. Now they're primary muscles that lift the arm overhead. So they really aren't made for that, and that's why we get a lot of problems. So those are the exercises I would do. Warming up before you play is great. The arm circles are a great idea. Like I said, a little Advil or Motrin. You can always get a cortisone injection if needed. And again, it is rare. I probably do 1 or 2 surgeries for shoulder impingement in isolation per year out of about 200 shoulder surgeries. So it's pretty rare, maybe 1%, if that. I think I did 1 last year. More often than not, they'll look like they have impingement syndrome, and then we get them in the OR and they actually have a frozen shoulder is really the primary problem. That's more common than to have impingement syndrome as the primary treating diagnosis for surgery.
Okay, I think I muted someone who was getting ready to ask a question.
Okay?
I'll ask, can you hear me?
Yes.
Yes.
Yeah, so I'm a 54-year-old male, very active, like work-wise. I use my arms and hands constantly, do all kinds of things. For the past couple years, I feel like I've been getting more and more pain in the tops of my shoulders, especially if I raise my arms and hands up in the air. I have pain at the tops of my shoulders.
Okay.
And actually, I have some of that pain where you described earlier in the upper part of my arm.
Yep.
And when I sleep, if I only really on my right arm, if I kind of lay on my stomach and extend my arm out, it's very painful.
Okay. So that could be a couple things. That could be impingement syndrome. That could be also something I didn't talk about, which is acromioclavicular joint or AC joint arthritis, which is very common. I have also been fortunate enough to have an old AC joint separation, so I have now post-traumatic arthritis there as well. So that is a very common. What kind of work do you do?
Like maintenance work, mechanical work.
Yeah, so anything you're working overhead, behind the head, pushing, pulling, dragging, whatever, that all exacerbates the shoulder. So it could be impingement syndrome, but I'd be suspicious if it's the top of your shoulder. It could be AC joint arthritis. That's very common, usually really treatable with ejection or medicine. Once in a while needs surgery. Unfortunately, there's no therapy or anything for that. It's either going to get better or not get better. And that's usually how that problem exists.
Let me ask you this, because I feel like at one point I started to kind of get back into, dumbbell weightlifting and whatnot.
Right.
And I kind of felt like the pain was I mean, obviously it was a little painful here and there while I was doing it, but overall I feel like I noticed that the pain was less after I did it for a little while.
Yeah, I mean, you might have been just conditioning those rotator cuff muscles a little better so that your function was a little better and things were more in balance.
So would you recommend that?
I mean, I would get back to those, like I just mentioned before, go on Google. I mean, if you come sit in the office, I have a piece of paper that has the exercises on it, but if you go on Google and you look up rotator cuff exercises, you will be inundated with pictures of the exercises.
Okay.
There's basically like 4 or 5 exercises you would do for the rotator cuff.
All right, I'll give it a try. Thank you.
You're welcome.
And it looks like we had another question come in. Car accident 2 years ago, small tear in rotator cuff, MRI inflammation, numbness in the left arm, tingling to fingers. Auto accident will not allow any more treatment. Physical therapy, trigger injections, injection in shoulder. Radiates to thoracic left side, left arm, 77 years old.
Yeah, I'd be suspicious this might be your neck and not your shoulder. Numbness and tingling usually does not go along with rotator cuff or shoulder problems. So I would probably have somebody take a look at your neck and see if that's where the pain's coming from. Because again, it's that kind of no man's land, that trapezius pain radiating from the back of the neck all the way down the arm, that's into the chest. That's more commonly your neck or cervical spine than the shoulder. We get a lot of people. I probably see 3 people a week they come in for shoulder pain, and it's actually not their shoulder, it's their neck. So it's very common.